Good afternoon, or good morning, good evening, wherever you are. Some of our panelists even are here in the late afternoon. I'm Michelle Heisler, Medical Director of Physicians for Human Rights. I'm delighted to stand in for PHR's Executive Director, Donna McKay, to welcome you all to today's webinar. Last March, we launched this speaker series on the health and human rights implications of the COVID-19 pandemic. Since then, it has provided a trusted space for healthcare workers, scientists, public health researchers, advocates, voices from the front lines to speak to the various impacts of the pandemic on public health systems, healthcare workers, and marginalized populations in the United States and across the globe. Thank you for joining us today. Our goal, as always, is to bring science and human rights-based analysis and approaches to guide responses to this public health crisis. Today, our expert panel will discuss how best we can leverage data and technology to track the pandemic, to promote global coordination in pandemic response, and to prevent future pandemics. What lessons have we learned from this and earlier global health crises to prevent and prepare for pandemics? How can they be used to enhance global coordination and response? George Santayana's 1905 warning resonates. Those who do not remember the past are condemned to repeat it. We have hundreds of you live with us today to listen to this remarkable panel of experts discuss these issues in terms of monitoring and response, including of utmost importance right now, how to ensure that vaccines are distributed equitably for the good of all throughout the world. I'm thrilled to welcome today's moderator, Dr. Céline Gounder. Dr. Gounder is a practicing HIV and infectious disease specialist, internist, epidemiologist. She's a clinical assistant professor in the Department of Medicine at the NYU Grossman School of Medicine. She is also an incredible public speaker, advocate, and journalist. She serves as CEO, president, and founder of Just Human Productions. This nonprofit multimedia organization examines the impact of public health on everyday life in order to inform healthcare professionals, policymakers, the press, and the public on their unique roles in bridging the health gap and building collaborative solutions to mitigate, address, solve health disparities, and promote health equity. She served on the Biden-Harris Transition COVID-19 Advisory Board. She is the host also and producer of the podcasts American Diagnosis and Epidemic, which I very much recommend to you. Dr. Gounder, over to you. Thank you very much for leading us through this crucial conversation today.
No, and it's great to be here with all of you. Thanks, Michelle, for that very kind introduction. As much as we'd like to think otherwise, the pandemic is sadly not over. Even here in the United States, we're seeing the impact now of the B.1.1.7 variant, which was first identified in the UK. We're seeing a surge in cases in the upper Midwest, led by Michigan, the Northeast, some of the Mid-Atlantic, as well as an increase in cases related to B.1.1.7 in Florida and now Texas. This is a also more virulent strain causing more severe disease. We're seeing young adults in their 30s, 40s, and 50s who are being hospitalized in these hard-hit areas for severe COVID. So this is sadly not over here in the United States and certainly not in the rest of the world. Unfortunately, we have had some recent setbacks in terms of vaccine supply, namely with respect to the Johnson & Johnson vaccine. The Emergent Biosolutions manufacturing plant in Baltimore has had some issues with cross-contamination between reagents for the AstraZeneca vaccine and the Johnson & Johnson vaccine. resulting in the loss of 15 million doses and perhaps more, depending on what the investigations into that matter show. So that's certainly been a setback, especially given the United States was really hoping to provide a tremendous supply of Johnson & Johnson vaccine for much of the world. The other key vaccine for world coverage is the AstraZeneca vaccine. And that also has seen some setbacks, as we know recently, with reports of very rare thrombotic side effects, so blood clot side effects, the most concerning one being the cerebral venous thrombosis. And as a result, some of the countries that had been using this have put a pause on their use of AstraZeneca or are using it in more limited populations. And so this is concerning because we were really counting on these two vaccines to get much of the world vaccinated. At the same time, we need to be monitoring for the emergence of other new variants, for the continued evolution of the variants that we're aware of, not just the B.1.1.7 that I mentioned, but also the B.1.351 that was first found in South Africa, and the P.1, which was first found in Brazil and is now spreading in places like Canada, for example. We also need to be monitoring and preparing for the next pandemic, because we do know that epidemics are emerging at a faster and faster rate over time. Over the last couple decades, we've seen many more epidemics than we had in the past. This is being driven by a number of different factors, ranging from overpopulation to climate change to deforestation and more. And so we have a really amazing panel to talk to you about all these different issues and how we'll be moving forward. First, I would like to welcome Dr. John Brownstein. John is the Chief Innovation Officer and Director of Computational Epidemiology at Boston Children's Hospital and a professor of pediatrics at Harvard. He's also the founder of the CDC's Vaccine Finder platform. So if you're having trouble finding a vaccine, you know now who to go to. He leads the healthmap.org disease surveillance tool, which was the first to identify and track the emergence of COVID in China. And he's also co-founded global.health, an open data set tracking COVID as well as future pandemics internationally. He's advised the WHO, Institute of Medicine, Department of Health and Human Services, as well as the Department of Homeland Security, and the White House on real-time public health surveillance data. Today, we're also joined by Sanjana Ravi, a senior analyst at the Johns Hopkins Center for Health Security. She's also a PhD candidate focused on health systems, and she studies infectious disease outbreaks, vaccine policy, health system strengthening in low and middle income settings, and the intersections between health, security, and human rights. And finally, Dr. Ronald Waldman, a former PHR board member, is a professor of global health at the Milken Institute School of Public Health at George Washington University. Over the course of his career, he's focused on pandemic preparedness and response, child health, and the control of infectious diseases in low-income settings, as well as humanitarian assistance to populations in response to natural disasters and armed conflict. He's been a leader at the CDC, USAID, and WHO, and he co-chairs the WHO UCH 2030 Working Group on COVID in fragile states and countries in conflict. He's also the president and chairman of Doctors of the World USA. So welcome to all three of you. I'm going to start really with a question. I'd love to hear all three of your responses. We already knew before this pandemic that coronaviruses had epidemic and possibly pandemic potential. We already had experience with SARS and MERS, for example. Did we have the disease surveillance capacity to predict or catch SARS-CoV-2 earlier? And what could have been done better? Maybe if we could start with John, then Sanjana, and then Ron.
Yeah, I mean, it's a really good question. And first of all, thank you so much for having me to this great panel. I think that it's a complicated answer because of the fact that we did have certain surveillance systems in place, and we've had many since even the time of SARS. We run a platform called healthmap.org, which does data mining for news and chat rooms and blogs and social media, where we get clues of what's happening in populations. And we're part of an ecosystem of efforts that are out there that are sort of scanning the online abyss, looking for those mentions of a report. And even as far back as SARS, our close collaborators at ProMed, which many people might be subscribers to, they leverage the astute clinician to find that signal in a population. And in fact, time and time again, whether it's SARS or MERS or Zika, these tools have shown that they can provide that early window into something that's happening in a population. So there's an underlying set of both sort of human effort plus AI that has been in play for almost 20 years. At the same time, we're dealing with a very set of scattered systems that are incredibly underfunded, that over time have really, started to wear significantly. Like the work that we were doing for many years is starting to get, completely underfunded. And, truthfully, there was no sort of either WHO level sort of surveillance tool other than sort of combining certain data sets that existed from the tools that we had. And then clearly, of course, within the US itself, the CDC did not necessarily have the true sort of capacity both to do global surveillance, but also local surveillance, because clearly we didn't even understand the emergence of COVID when it was in our country. And so, truthfully speaking, we had some of the components, but we didn't have all of them. We know that COVID emerges as a zoonotic pathogen. We did not have the right types of surveillance at the human-animal interface. We didn't have the syndromic reporting tools that really could provide us deep insights of what was happening in China at the time. We didn't have laboratory capacity. We didn't have the diagnostic tools. And so much had to be done in real time through the pandemic, an incredible amount of innovation. Our colleagues at Johns Hopkins, for instance, pulling together amazing technologies. But, this was all built in real time. And, when you're dealing with an emerging infectious disease, having to build the plane as you're flying it just doesn't make sense. And so, I'm sure we'll talk throughout this session about sort of the ways in which we can get there for the next pandemic. But of course, we were nowhere near where we needed to be for the time of COVID.
Sanjana?
Yeah, thank you, Dr. Gounder, and thank you, Dr. Brownstein, for kicking us off. I would say that, we have known for a long time, like you said, Dr. Gounder, that coronaviruses have epidemic and sometimes pandemic potential. And, from what we know about the origin of the COVID-19 pandemic, the initial cluster of cases that was reported in Wuhan was detected and reported fairly quickly. And more recently, we've also learned that Chinese officials shut down not only the seafood market in Wuhan that was linked to those first cases of COVID back in December 2019, but also the wildlife farms that were supplying those markets. So, I'm not really sure how much sooner cases of a novel disease like COVID-19 could have been detected, especially given the somewhat lengthy incubation period of the illness. But that being said, I do want to acknowledge that, predicting whether a given virus will actually make the jump from an animal to a human is incredibly difficult. And that's been a critique of the United States now defunct PREDICT program, which was shut down in March of last year. But with more proactive efforts to identify and catalog and sequence novel viruses in potential hotspots at that human-animal interface, the global community may have been better prepared to develop rapid diagnostic tools, ramp up laboratory and testing capacities, and also coordinate regional surveillance strategies when SARS-CoV-2 did eventually make that jump, spill over into humans from animals, and start to spread. And to Dr. Brownstein's point, I would definitely agree that bolstering syndromic surveillance capacities for humans could also help us identify more quickly when those spillover events take place, such as when someone presents to their doctor with an unusual fever. And also, with increasing globalization and climate change, that having that capacity, I think, could be especially valuable, especially in settings where animals and humans live in close proximity, or in settings experiencing ecological degradation or major land use changes.
Thank you for that, Sanjana. Ron, do you have anything to add on what we could have done better?
Yeah, hi. Thank you, Dr. Gounder. I turned my video off because my internet connection's a little bit shaky and unstable. So I hope that it will hold up for the duration of the conversation. I want to thank PHR for the opportunity to be here. And I wanted to offer my condolences to Physicians for Human Rights on the loss of both Jack Geiger and Carola Eisenberg, two giants of human rights. Especially for underprivileged and marginalized people around the world who both passed away in the past few months. In regard to the question at hand, I think that it's great that we do have at least some tools that allow us to detect the emergence of a new pathogen, a potential pandemic, as quickly as possible. But doing so is valuable in terms of being able to mount a rapid response. It doesn't necessarily mean that we're prepared. I think we do have to have a lot going on, even including the strengthening of surveillance, in order to allow us to be sure that our response will be able to result in a maximum reduction or prevention of morbidity and mortality. There have been efforts to do so in the past. Most of them have been interrupted, either by other pandemics or by a shift of funding to other priorities. And I just hope that during the course of this conversation, as much focus as we need to put on early detection of the virus and on controlling the spread of the virus, we really need to insist that preparatory activities take place in the inter-pandemic period throughout all of the different sectors of society, and that needs to happen in an integrated and coordinated way. We're nowhere near doing that with any of the tools that we possess.
Well, and sadly, it's that U-shaped curve of public health concern that we see, right? Where you have a lot of money, resources, attention when there's an outbreak, and then that all evaporates in between until the next one. One of the things that I think this pandemic has illustrated is that we really do have to build up our laboratory capacity, our technological bioinformatics capacity. And that's not just globally, that's even here in the United States, we have real deficits in that space. John, maybe if you could tell us what are some of those deficits and what is being done, what needs to be done to address them?
Yeah, I'll talk a bit about on the surveillance front. Of course, we had some level of surveillance both globally and nationally, but clearly we saw what happened here in the US where outside tools, COVID tracking project and, COVID Act now, tools that are incredible just got built because of a lack of ability for us to see data that should be really provided by the government. Now, we've seen a quick sort of response in the new administration and an incredible amount of transparency and data, but that's not quite enough because that provides a situational awareness. It doesn't give us that sort of sense of where, the trajectory of where something is headed, especially in the case of a new emerging virus. And what we've seen previously is a very sort of organic set of academics that have come together to build models to forecast disease. While that being incredibly valuable, there's sort of no sort of discipline that is being driven by the government to really provide forecasting at the same level as, say, the National Weather Service. And I've colleagues, Caitlin Rivers and Dylan George, who proposed this idea of a national disease forecasting center. In fact, that just got allocated, $200 million, which I think is phenomenal because for the first time, we're going to have the infrastructure to really push disease forecasting as a discipline and something that is actually being driven by the government. Now, of course, that's going to take both the private sector and academia, but I think that at least is a starting point to get us to where we need to be to really push this area forward, both in terms of projecting out, epidemics within this country, but also when we see something emerge, what does that, can we build in additional data sets like travel data, climate, how do we make real projections of risk, in the same way that we've thought about weather. So I think that's, I'm optimistic about that. And of course, in parallel, we've seen similar investments in genomics and lab capacity, but maybe I'll let my other panelists chime in, see what they think.
Yes, Sanjana, what do you think? Oh, sorry, go ahead.
No, it's fine, I can wait. I'll go ahead. I just wanted to ask John, So the disease forecasting activities would be great. I've been really surprised during this outbreak, to tell you the truth, about how unpredictable the course of the outbreak has been. The virus has behaved somewhat, I would say, erratically, variants or not. There have been different surges in different places at different times. And it's been very difficult, I think, to follow the motion of the outbreak itself once it began. So would the same kinds of tools be useful in being able to predict not only when an outbreak or a pandemic might occur, but its course over time and over place and over person?
Well, I can chime in. Yes, so I think that on one hand, for disease forecasting is very complicated because there are so many factors that go into this, and we clearly saw some of the challenges, especially early on. Some of the IHME models that came out that were a bit, off because we didn't fully understand the virus. Some of the models may have been ultimately curve fitting exercises, and so I think we learned a lot. I think overall, we've been able to generally predict surges. There's been sort of clear signs, reduction in social distancing, reduction in mask wearing, mobility has led to surges, and that's been quite predictable. But the science has really evolved in this space and in disease modeling throughout the pandemic. And my view is some of those learnings can be brought to bear on a future emergence events, whether it's a coronavirus or another pathogen. Clearly, we have the most amount of learning in influenza that we apply to coronavirus, but there's a whole discipline that needs to be funded to really optimize some of these models.
Yeah, it's an interesting question, right? Because the Northeast, Michigan were some of the hardest hit places early on in the pandemic, and we're seeing those being hit again now with B117. And we saw later southern states last summer being hit hard. Many of us have been wondering, are we going to see a similar sort of evolution geographically repeating itself this year? Does that even make sense? But it is an interesting question. Now, this question is perhaps for Ron and then Sanjana. Whose responsibility is it to build on the global level, to build and fund this kind of surveillance capacity, and why?
Well, I think the easy answer is to say that it's all of our responsibility. But I think that if one's looking for an organization that should take the lead on a global level in terms of these specific health activities like building surveillance systems, I think one's thoughts immediately turn towards the World Health Organization. Mm-hmm. And I think that they have done a reasonable job throughout this pandemic. They sent a team to China fairly early on. They delayed a little bit the declaration of a public health emergency of international concern. And I think, that might have had some consequences, but I would answer briefly the World Health Organization, but I want to come back again, and it's going to be my role throughout the next 45 minutes or so, to say that a pandemic is not only a health issue. It's a whole of society concern. And I am not sure that the World Health Organization is the best place to look across all sectors of society. I think they've made several statements, including some recently calling for an international treaty for pandemic preparedness and response. And they position themselves as the potential leaders. For me, I would say that the jury is out as to whether that's the best place to put a international, coordinated, multilateral preparedness body, especially in regard to whole of society monitoring and research activities, which are very much part of this. A number of colleagues and myself have suggested at times that perhaps, because pandemics are an existential threat in the same way that climate change is. On the climate change side, you have the IPCC, Nobel Prize winning body that is responsible, independent and responsible for monitoring suggesting, promoting, following, and advocating for more and publicizing research across the board in climate change, it might be that something like that would also be called for in terms of moving forward with pandemic preparedness as well.
Now, whether it's something analogous to IPCC or that it remains at WHO, is a body like WHO adequately funded and empowered to do the work we all expect it to do? And if not, what would need to be done to strengthen the organization? Perhaps Ron and then Sanjana, if you want to take that.
I can be very brief on the first part of your question. The answer is no. We all know that the funding for this activity isn't even nearly what it needs to be. Again, it's another reason why one might want to have a separate standing body that can be given adequate funding from the start. It doesn't have to be huge. It doesn't have to be a huge operation, but even within the World Health Organization, there are so many competing priorities, so many other health issues on the table that it's hard to get real across the board support for emergency preparedness activity. Response is something else. You mentioned before, Dr. Gounder, what you talked about, the variability in funding when we have something in front of us and when we're a little bit blinded to it. We call that the cycle of panic and neglect, basically. And I guarantee that when this pandemic is deemed to be over, that we will re-enter a period of neglect of the potential. We've said, or I like to say, I can say for the infinitieth time that the next pandemic is a question of when and not if. But one question that you mentioned to us earlier was, what are the lessons that we've learned? Sometimes I feel it's easier to count the lessons that we have been able to identify but have refused to learn.
Sanjana, what do you think? What would need to be done? What kind of organization, would it be something analogous to the IPCC? And how would that be different from what we have with the WHO right now? And how whether it's an analogous organization to IPCC or WHO, how can we strengthen their ability to do the work that they need to be doing in terms of emergency preparedness?
Yeah, it's a really important question, and I do want to acknowledge that while WHO has certainly received its fair share of flack for its response to this pandemic, some of it well earned. I think there are some things that it actually did well. It's been quite proactive in terms of sharing genetic sequencing data with scientists. It declared a PHIC fairly early on in the pandemic, and eventually started urging countries to implement protective measures like contact tracing and testing and quarantine and so on. I also think it's worth bearing that, for all its faults, it does have a mandate to serve primarily as an advocacy and standard setting organization that provides technical assistance to countries and convenes relevant stakeholders and partners. It was not really built or funded or equipped to serve as a rapid response agency. And to Dr. Waldman's point, it has been incredibly constrained by its chronic lack of funding, as well as by the influence wielded by select member states and the lack of tools at its disposal to enforce global norms and provisions of the IHR. And I think COVID-19 has really underscored the need for stronger international leadership. WHO may or may not be the right organization to provide it, but given its position in our global health security architecture at present, if it can be equipped to do so, at least in the near future, I do think it has potential to start transitioning the world to a stronger position of preparedness.
John, are there some parallels here between WHO and CDC's weaknesses? I mean, it seems like part of the challenge is that they are largely technical advisory organizations and don't necessarily have the operational boots on the ground capacity to do some of what many expect them to do or think they can do.
Yeah, I mean, it's very similar, right? Because with the CDC, they defer to local public health. That's, in this country, it's not the CDC that is going in and doing the work on the ground. They're relying on state and local public health to do the data collection. And it's the same issue. The states and local health departments are chronically underfunded. They don't have the resources to build the capacity whether it's surveillance or around testing or vaccines. I mean, this has been the challenge. My lens is on the technical front. And the reality is there's no way that, a WHO, a CDC, especially not local public health, can have the capacity to build the technology that is required to capture the data needed, to develop the tools, develop the visualizations. It just doesn't exist. And this is where the partnering becomes super critical. I mean, we've seen real entries from a lot of the big players through the pandemic. We've had amazing partnerships with Facebook and Google, who have released a huge amount of data on both surveys and population mobility. These are incredible data sets that we would never have seen. In decades that I've been doing this, I've never seen the kind of data that has been made available from those tech companies to be able to monitor the health of populations in real time, provide syndromic surveillance at a global scale, be able to understand movements of populations. I mean, this is critical data for surveillance and for response. And so the big question now remains, can we get those tech companies to continue this level of engagement, to partner, to provide the resourcing to organizations like WHO, CDC, which will never have those kind of resources. My big fear, of course, is the minute we feel like we're on the other end of this, we're going to just be back to where we were right before the pandemic. And that's been my fear. So much has been built, so much capacity is there right now. And, are people going to just walk away from it? Or are we going to find a way to keep this new level of data sharing, of resourcing for the next pandemic? And I think that still, for me, that remains a huge question mark.
Sorry, go ahead, Ron.
Yeah, I just wanted to say it's really important. Michelle opened by quoting Santayana, and I was a history major in college, so let me give a little history as well. In 2005, we were living at a time when there was a major threat perceived by scientists of an imminent pandemic from H5N1 influenza virus. And a considerable amount of money was put into preparedness at that time. The UN even formed a supra-agency called the Secretariat for Influenza Coordination. It was headed up by Dr. Nabarro and David Nabarro, who was a very prominent global health practitioner, and reasonably well funded, with most of the money coming from the US Agency for International Development. That office was intended to work in many, many countries and throughout all of the different sectors of the country. It was done as a separate agency because it needed to call on cooperation and coordination from all of the various UN agencies that cover very different domains. It was going pretty well. It was working fairly efficiently and fairly well until the outbreak of the pandemic, of course, in 2009, the H1N1 pandemic, influenza pandemic, at which time all of the preparedness funding was shifted to response. One could argue whether that was appropriate or not, but suffice it to say that the money never came back to pandemic preparedness and left us a little bit where we are now. That led ultimately to the formation of the Global Health Security Agenda, the joint external evaluation. So I want to point out only that there were many predictions of what would happen in a pandemic and many rankings of countries as to which were the most prepared for an upcoming pandemic. And the things that were looked at and figured into those rankings were the strength of surveillance systems, the strength of laboratories, the strength of vaccination services, and on and on and on. But there were so many things missing as scoring criteria that those indices proved to be way, way off base. The US, of course, was ranked #1 with the United Kingdom close behind, other Western European countries. They just didn't perform well at all. Why? Because they left out some critical factors. They left out the vital role of political governance. They left out the legitimacy of government. They left out factors like trust that people have in their governments. So many different things that we've seen come up again and again in different countries during the course of this pandemic. I think we have to go back a little bit and revisit what had been done previously, because that Office of Pandemic the Secretariat for Influenza Coordination that I mentioned ultimately produced a document called Towards a Safer World that has chapters in it on, I'm looking at it now, on health, of course, first and foremost, on the health sector, but also on civil military collaboration, on community level preparedness, animal health, private sector preparedness, which needs to be taken into account, risk communication, supply chain and logistics, so many different things. So we need to have, I think, a standing body receiving dedicated funding that can work across the whole of society, identifying gaps in research, monitoring research, and evaluating progress on an ongoing basis. Sorry to take so much time. You can see I get a little bit worried about this.
You're passionate. Next question is for Sanjana, and then John and Ron, and then we'll start with some of the audience Q&A. Many of us are really concerned about equity in this moment, equity here in the United States, equity overseas, equity with respect to the disproportionate impact on certain populations, with respect to distribution and access to vaccines, and also with respect to confidence in these vaccines. Is the US doing enough to ensure equitable vaccine distribution globally? And what more could we be doing?
Yeah, it's a very, very important and relevant question, I think. I'd say that, in general, epidemics and pandemics, like most public health emergencies, have this very uncanny ability to really expose the faults in our social fabrics and our norms and our systems, and COVID-19 has been no exception to that. Very early on in the pandemic, we saw disproportionately high morbidity and mortality among communities of color here in the US. And at the same time, we've also seen some of the lowest levels of vaccine access and uptake among those very same groups. While the national vaccination effort is picking up pace in the US, which has been really encouraging to see, there is still substantial room for improvement. Most vaccine appointments, for example, are only available online, which excludes very large swaths of the US population that lack internet or computer access. Vaccine hesitancy appears to be declining nationally, but is still pretty persistent in some demographics that may lack access to reliable information about the vaccine, or who are deeply distrustful of government institutions. Then there are people with disabilities or senior citizens who may be homebound and physically unable to make it to a vaccination site. And though the vaccine itself is offered for free, some folks might still have to take time off of work or pay for transportation to the nearest vaccination site. And these examples, I think, are all symptoms of longstanding systemic inequities that are very deeply entrenched in the fabric of our American life, and will require long-term systemic solutions. But I've been encouraged to see that the Biden administration so far has laid out plans to accelerate vaccine distribution and uptake domestically, such as a $1.5 billion ad campaign to improve national vaccine confidence. In terms of health system solutions to vaccine inequity here in the States, I think a really valuable lesson that the US could stand to learn from other countries is the value of having a robust standing cadre of community health workers. So these are trained individuals with relationships and inroads into hardly reached or underserved or otherwise marginalized communities that have limited access to vaccines. Some of the surveillance technologies we discussed earlier, social services they may qualify for, and other really important information about COVID-19. Many countries, including and especially low and middle income countries, have developed really innovative ways of leveraging community health workers to administer both routine and emergency vaccination programs, which again is a lesson that I think the US could certainly stand to learn from. It was great to hear President Biden back in January commit to creating a new community health workforce. And the recently passed American Rescue Plan Act of 2021 does include provisions for recruiting and training community health workers via public health departments. But I think the long-term challenge for us in the US moving forward will be sustaining that investment over time and sort of reversing the manufactured state of fiscal austerity that has unfortunately characterized state and local public health here in the US for the last several decades. In terms of what the U.S. could be doing better internationally with respect to sharing vaccines, unfortunately, my general sense, and I would love to be wrong about this, but my general sense is that the global vaccine distribution effort seems to be driven more so by politics and precarity than by the data and evidence we have about, where new variants are emerging and where cases and morbidity and mortality seem to be the most severe. I believe it was reported just a couple of days ago that the contract signed by the Trump administration and COVID vaccine manufacturers included a clause that prohibits the US from actually donating some of these vaccines overseas. And so my hope moving forward is that the global vaccine distribution will be eventually driven by risk and need and ethics, just as we've strived to do here in the United States.
Yeah, actually, to that point, the way the administration worked around that and was able to provide some doses to Mexico and Canada is to provide them on loan. And so I do think there are some workarounds. Another would be working with the receiving country to take on the liability, because that's what a lot of these restrictions and the contracts are about. John, what do you think here? What could we be doing maybe in a data-driven way to improve equity at the global level?
Yeah. All right. Well, my lens definitely is in the US rollout. So I'll start there at the very least. So we've been running a tool called Vaccine Finder for the last 8 years, ever since H1N1, where we built a tool to help people find vaccines in the community. But the reality is the technology around thinking about how to drive better access to vaccines is sorely underfunded. We put huge amounts of investment on the discovery side, the R&D side, the production side. And then, and you probably know this better than anyone, having learned a lot about the discussions, we then realize, oh shoot, we need to think about a rollout plan that sort of is at the same scale and thinks about equity in terms of access. And that, sort of came a bit late, frankly. There was a lot, again, as I mentioned, we're building technologies around vaccine distribution in real time again. And then, of course, having to think about, where the gaps are in that distribution. We through the Vaccine Finder program, which was launched about a month ago, we work with all the federal pharmacies, all the major sites that provide vaccine. And from there, we have 50, 70,000 locations. That's a great amount of distribution. There are significant gaps in who has access to the vaccine right now. We call that vaccine deserts. And in fact, when we've done our analysis, about 30 million people live in a vaccine desert, either because they have to drive too far to get access to vaccines or because there's just not enough supply in those places. So you may, of course, think of rural areas of this country to be in vaccine deserts, but actually certain urban centers like Chicago and Detroit, there are incredible divides in terms of who has access to the vaccine. Non-white neighborhoods being more represented by independent pharmacies, not having the same access to the vaccines. They are sort of not provided at the same rate as, say, white neighborhoods. And so there's very clear divides that we see, again, racial lines, again, against economic lines. And then, of course, it just exposes us the same issues that we've seen throughout this pandemic, both in terms of outcomes, but also in terms of what we saw initially with testing. And it's the same thing repeating itself again with the vaccine rollout. Now, what's good is that we're producing these vaccine desert maps. They're being fed back from a policy perspective, and then we can start to think of where we fill in the gaps, whether it's pop-up vaccination sites, mobile clinics, federally funded efforts to really make sure that there's improved access. I think that at least that flow of information, that cycle of information is occurring at this stage in the pandemic to the point where we can make sure that we're making up those differences. And now the only other issue, of course, is not just about pure access, it's about hesitancy. And what we're seeing right now is as much as supply is being distributed across this country, administration rates are slowly starting to decline. That proportion of available doses is going up. And that's because probably what we're seeing is there's a capacity issue, but there's also the hesitancy issue, and that's going to get exposed. And I think in the next several weeks, we're going to see those issues much more clearly what we had when all that sort of initial demand sort of gets used up and that supply starts to outweigh it. So it's going to be some really interesting issues around education that will come in the next month, if not sooner.
Yeah, I think that's a great point about the independent urban pharmacies, especially those that serve largely Medicaid and Medicare populations. They're much more likely to have shuttered in the last several years, particularly during the pandemic. Ron, is there any reason to hope that we might overcome nationalism and politics and be more equitable in our global distribution efforts?
When it comes to hope and optimism, you're talking to the wrong person. Congratulations, John. I think it's really important that we have the kind of work that you're doing. But I do think it's shameful, in fact, that these deserts do exist. But I work more on the global side. And if we have a desert, I wouldn't even know how to describe what we would have on the global side in terms of vaccine distribution. Even in Europe, the vaccine rollout has been absolutely just incredibly slow. And globally, the numbers I've seen remain embarrassingly low. And, especially with PHR being an organization of human rights advocacy, we're not helping people to get access to the protection they need. I fully agree. And I was so happy to hear Sanjana say that distribution of vaccine equity means really fair distribution by risk and not necessarily by population. So I do agree with that. I wanted to throw one little maybe monkey wrench into the works by saying that I think the US could do a better job. Maybe I'd like to hear everyone's take on this. If you look at the UK, which is not far from where I live, they're able to donate more vaccine by delaying the second dose, right? I think you have a little bit of a middle road here between the two ways of equity. There's no getting around their numbers. They've been fabulously successful with the first dose of their vaccine in terms of reducing the number of cases, hospitalizations, and deaths that they've had. Dr. Gounder, I happen to have seen, I think, a tweet or something where you said that you yourself were maybe moving a little bit on this issue, having once opposed loosening the vaccine schedule to allow for a delay in the administration of the second dose. I think it would be appropriate to ask you what your current take is.
I have moved back to my original stance on this, which is to stick with the current schedule. And it's for a couple reasons. If you look at the data out of Scotland and you look what happens 4 or 5 weeks after the first dose, you definitely see a drop in vaccine effectiveness. It peaks at about 85% in terms of protection against hospitalization. Out of that data set, and then you start to see a decline in vaccine effectiveness versus against hospitalization, which means that your effectiveness against infection is going to be even lower. So that's one data point. Another is a paper out of the Planus lab looking at B117 and B1351 and sera from vaccinated persons, neutralizing antibody titers elicited by the vaccines, the Pfizer vaccine at multiple time points, including between the first and second doses of vaccine. And even with B117, and this is what I thought was actually even more concerning because this is the dominant strain here in the US, your titers against B117 from the Pfizer vaccine after only one dose were just not as, you needed much higher titers, and not everybody after one dose had the titers they needed to be neutralizers. So I think it was something like 30% or so had achieved that level. And so that is concerning because if that is the dominant strain now in the United States, and then you were to create a window of opportunity for immune pressure to select for B117 with the E484K mutation, I think that would really leave us in a bad position. Obviously we are trying to prepare for, some of these variants, including B1351. Whether that means giving a third booster dose down the line, whether that means a second generation vaccine, we're still not sure yet. But I do think that there are significant downsides that might actually create a bigger problem for us down the line. And so I think at the very least, if you're going to pursue that, we need much more rigorous studies of one dose, and you really do test them for infection as well as the harder endpoints over a 12-week period. And that has not been done yet. We just have real world data. And I think it's sort of similar to some of the debates we had about TB and HIV, sort of that's my former world. Do you start antiretrovirals early in the course of TB treatment, or do you wait until you've completed TB treatment? And so there was a lot of concern that you might induce this hyperinflammatory, what we call iris reaction, if you started antiretroviral therapy too early. And part of, I think, the bias also came from the fact that the person treating for TB only saw that patient for the first 6 months, 9 months of treatment. They weren't necessarily there to see what the impact was on mortality. And what we have learned from multiple studies is that the mortality benefit of starting antiretroviral therapy early in the course of TB treatment, there's a very clear mortality benefit. And I think there's a similar sort of thing playing out here, where you see the early impact on hospitalizations, in the UK, for example, from this dose delay, but we haven't yet had the time to see what might be the consequences in terms of selection for immune evading variants. And so our bias is to react to what we see and what has not played out yet. So that would be my take on it.
I think, and I'll just chime in because I actually fully agree. I'm on that same side based on the data or lack of data that we have. But then I'm also, and I think it probably works better in other countries where there's probably a better relationship between the population and scientists and the government. And I just think here, we know there's a huge mistrust around FDA and the approval process and science, and changing course. We're going to start to see the emergence of pockets of population that are hesitant and concerned about these vaccines. And I do think changing mid-course, I think around, creating a course of vaccines that wasn't part of the clinical trials, I think it may have unintended consequences that could really undermine the vaccine role. But that's my perspective. So in addition to the data, I think there's that concern.
An answer to the question of whether it's in what way is it ethical or equitable to vaccinate low-risk Americans before giving access to high-risk citizens from low-income countries to the vaccine.
Well, that's a different question, right? Because that's really, should we just ship all of our vaccine over there and give 2 doses to somebody elsewhere? I mean, that is a good question. Whether that, I think, unfortunately, that is just not a scenario that is likely to happen, where countries would give up their own supply. Their first obligation is to their citizens. And so I do think there is going to be some degree of nationalism, whether that's right or not.
I think that there will. I don't know that it's right or not, but I think that there will be for sure. That's why I'm suggesting that if it's possible, if the evidence doesn't support it, I'm the last person to want to do it. But I think that if it were to be possible to find some way to provide an adequate level of protection within the wealthier countries, while being able to send more vaccine to cover high-risk individuals in low-income countries, I think that's what the World Health Organization is calling for. I think that's what we should all be supporting. That's my opinion on that.
Mm-hmm, mm-hmm. I don't want to ignore the, do we have any questions from the, okay. Oh, we're down to 5 minutes, so we don't have time for any other questions. I just want to take one question really quickly. If we can do just a 10-second round robin from the 3 of you. What is the most important lesson you've learned from this pandemic? Maybe Sanjana first.
Sure. I'll try and do this quickly. But in the U.S. at least, I think our pandemic response has taken a very sort of technocratic approach. We're relying very heavily on testing and vaccination to sort of weather the storm and resume with daily life. But I think one of the most important lessons from this past year, for me at least, has been that a robust social safety net is just as critical a tenet of pandemic preparedness and response as vaccines and testing and contact tracing. So much of the US response and our epidemiological trajectory in this pandemic have been shaped by a motivation to protect economic interests, which we've seen in the form more recently of premature reopenings of bars and restaurants, the absence of mask requirements in some places, et cetera. But unfortunately, that's forced non-salaried workers in the US to go back to work in potentially unsafe environments, thereby maybe prolonging the pandemic. But in other countries like New Zealand, Vietnam, several European countries, we've seen national governments really step up and start subsidizing workers' wages. In Portugal, free healthcare was extended to migrants living in country. Thailand and Canada both issued monthly checks for extended periods. So the pandemic has really underscored the importance of caring for the most vulnerable people in society. And I think the countries I mentioned and others have risen to the occasion in ways that the US could certainly learn from, I think, because not only do investments in the social safety net reduce some of those socioeconomic inequities that we discussed earlier, but they can also help incentivize public cooperation with prolonged outbreak mitigation measures.
Thank you, Sanjana. 10 seconds. John and then Ron.
All right, very quickly, it's all about open data sharing. As an academic, public health, unprecedented levels of sharing of information that turns out doesn't undermine economic activities of a country and also doesn't undermine your academic aspirations. And so that is a lesson that I hope extends to future pandemics.
Ron, any closing thoughts?
10 seconds.
The importance of political leadership. 2 seconds.
Well, thank you. This was a really fun conversation. I wish we could have gone for longer because I think there's still so much more to discuss here. I'm going to turn it back over to Michelle for last couple comments and closing.
Yes, thank you to all of you for a really thought-provoking discussion. Thank you for guiding us through some of the forecasting, surveillance, data systems, and sharing, organizational structures necessary, including building stronger safety nets, necessary staffing, and the funding mechanisms and political leadership we're going to need to build, to, in Ron's words, move beyond the cycle of panic and neglect. I think I appreciate that. That's going to go up there with Santayana in terms of what we have to move beyond. And I will say you all raised critically important ethical questions and political questions as well. So thank you. And again, thank you, Céline, Ron, Sanjana, and John. And Céline, thank you also for both your beautiful moderation and for adding your own expertise to the discussion. Please, everyone that's on, do stay tuned for our next webinar. It will be April 16 at 10 a.m. Eastern. We'll continue to address this critical importance, as Ron has emphasized, of learning from the past. And in this case, we will focus on really what are some of the lessons learned from the specific HIV/AIDS epidemic. A number of you also, Céline and others, are also experts in HIV. But as we think about that, there are so many important lessons from failures, as well as some of the successes in responding to HIV/AIDS. And so our PHR Advisory Council member, Dr. Chris Beyer, will be moderating that. And we'll have Dr. Eric Goosby, Dr. Diane Havlier, as well as Dr. Salim Abdul Karim, to really focus on that particular, kind of honing in on some of the really important themes that you all raised today. So I hope all of you on the panel will also join. Yeah, it's also your area of, an area that a lot of you have a lot to offer on if you're in the audience asking questions. So thank you, and good night to some of you, and have a good rest of your day to the others.
Thanks so much, everyone.
Bye-bye.
Bye.